Welcome to Vet Image Lab. This is part 2 of our echocardiographic series on feline hypertrophic cardiomyopathy. In the last lecture, we discussed how to identify left ventricular hypertrophy and how to measure wall thickness using 2D and M mode. In part 2, we'll explore different patterns of hypertrophy and dynamic left ventricular outflow tract obstruction and discuss their clinical significance. Understanding these patterns is essential, not only for accurate diagnosis, but also for determining appropriate medical treatment for HCM. Let's get started. You should remember that left ventricular hypertrophy can present in several different patterns. In global concentric hypertrophy, as shown on the left image, the wall thickening is symmetric and uniform across the entire ventricle. This is the most common form we see. This is another case. On the long axis view, both the interventricular septum and the left ventricular posterior wall are severely thickened. This is marked global left ventricular hypertrophy. However, in asymmetric hypertrophy, as shown in this image, the left ventricular wall may be thicker than the interventricular septum, or vice versa. In some cases with HCM, focal segmental hypertrophy occurs with regional wall thickening, such as the basal septum, papillary muscles, and mid-ventricular region. For this reason, it is essential to carefully evaluate the entire left ventricle during the scan to avoid missing these focal abnormalities. Here is an example of focal hypertrophy involving the basal septum. Compared to a normal heart with symmetric wall thickness on the left, on the right, you can clearly see that the basal portion of the interventricular septum is thickened, approximately 7 millimeters, while the left ventricular posterior wall remains within normal limits. This is another case. Here you can see focal hypertrophy located at the basal portion of the interventricular septum. On the color Doppler image, there's turbulent flow detected within the left ventricular outflow tract, caused by narrowing due to the thickened basal septum. This is actually the most common form of focal hypertrophic pattern seen in cats. It often leads to dynamic obstruction of the outflow tract, especially during systole. Focal hypertrophy can involve papillary muscle thickening as early or variant forms of hypertrophic cardiomyopathy. It can be challenging to detect because it doesn't present with global thickening. In this form, both size and shape of the papillary muscles should be assessed carefully. You may see elongation, bulging, or asymmetry, often in the anteromedial or posteromedial muscle. In some cats, hypertrophy may affect only a single papillary muscle. This is an example of asymmetric papillary muscle hypertrophy. If there is uncertainty about whether the papillary muscle is truly hypertrophied or simply prominent, serial follow-up examinations are often critical. In this cat, you can also see that one of the papillary muscles appears large and hyperechoic, while the other remains within normal size and echogenicity. Another important focal pattern in hypertrophic cardiomyopathy is mid-ventricular obstruction. Hypertrophy typically occurs near the papillary muscles or slightly apical to them, as marked by the yellow arrows here. So, this pattern creates an hourglass appearance of the left ventricular cavity. Mid-ventricular hypertrophy affects the ventricular walls and leads to partial or even complete dynamic obliteration of the mid-cavity. Color Doppler may reveal turbulence, localized within the mid-ventricular cavity, as shown in this case. This turbulent flow pattern helps us differentiate mid-ventricular obstruction from left ventricular outflow tract obstruction. In LVOT obstruction, the turbulence is seen near the aortic valve, and it is frequently associated with a focal hypertrophy pattern at the basal septum. Clinically, systolic cavity obliteration increases apical pressure overload, which may result in apical aneurysm and elevate the risk of ventricular arrhythmias and thrombus formation. This is an example of mid-ventricular obstruction in a 16-year-old American shorthair cat. You can clearly see mid-ventricular hypertrophy. Color Doppler imaging shows turbulent flow localized at the mid-ventricular level, not in left ventricular outflow tract. Also, note the left atrial enlargement in this case. Before we move on to the next parameter, let's briefly summarize the different hypertrophy patterns and their clinical relevance. The global or diffuse form is the most common pattern. It can result in either symmetric or asymmetric thickening of the left ventricular walls. Among the focal hypertrophy types, basal septal hypertrophy is relatively common and often associated with systolic anterior motion and dynamic left ventricular outflow tract obstruction. Papillary muscle hypertrophy may contribute to SAM and changes in chordal tension. Mid-ventricular hypertrophy, though less common, can cause mid-cavity obstruction and apical pressure overload, increasing the risk of apical aneurysm and thrombus formation. Finally, apical hypertrophy is quite rare and may be easily underdiagnosed without careful imaging of the apex. Understanding these patterns is essential for accurate diagnosis in cats with HCM. Next, you should evaluate to determine whether LVOT obstruction is occurring. Left ventricular hypertrophy does not always result in left ventricular outflow tract obstruction. For typical LVOT dynamic obstruction, the presence of systolic anterior motion of the mitral valve is required. Let me show you an example. In this cat, we can see left ventricular hypertrophy, but there is no evidence of blood flow obstruction on color Doppler image. You should carefully evaluate each case to determine whether LVOT obstruction is truly occurring. Let me show an example of a normal LVOT first. In a normal heart, the mitral valve stays well away from the left ventricular outflow tract during systole, allowing blood to flow into the aorta without any obstruction. The flow remains laminar, with uniform velocity and direction. As you can see in a normal heart, the mitral valve opens during diastole and comes close to the interventricular septum. Then during systole, it closes away from the septum, allowing unobstructed flow through the left ventricular outflow tract. But in cats with hypertrophic cardiomyopathy, as the interventricular septum thickens and the shape of the left ventricle becomes altered, the position of the papillary muscles are often displaced apically. These structural changes alter the tension and orientation of the mitral valve. The displaced papillary muscles pull the mitral valve cranially toward the interventricular septum. This is what we call systolic anterior motion, or SAM. During diastole, the mitral valve opens and comes close to the interventricular septum, just like the normal heart. Here we have captured a series of images showing the motion of the mitral valve throughout systole. MV motion is indicated by the white arrow. On the left image, at the early phase of systole, you can see that the tip of the mitral valve starts to bend slightly toward the interventricular septum. As systole progresses, shown in the middle image, the mitral leaflet continues to move anteriorly toward the septum. Finally, by late systole, seen in the right image, the mitral leaflet nearly contacts the septum, significantly narrowing the LV outflow tract and obstructing blood flow. Can you see the abnormal anterior motion of the mitral valve in this video? If you use the trackball on your ultrasound machine to scroll slowly through the cardiac cycle, frame by frame, it is much easier to clearly evaluate the motion of the mitral valve. SAM can also be evaluated using M-mode imaging. The M-mode cursor is positioned through the tips of the mitral valve leaflets and the interventricular septum. Here you can see a magnified portion of the M-mode image to better visualize the motion of the mitral valve and its relation to the septum. During systole, you can see the anterior mitral leaflet moving closer toward the septum and contact the septum during mid to late systole. M-mode is especially useful for determining the timing and duration of septal contact throughout the cardiac cycle. But I recommend using B-mode because slowly scrolling through cine loops often makes it easier to identify SAM. With systolic anterior motion, the narrowed left ventricular outflow tract creates turbulent flow during systole. Color Doppler can be used to detect the dynamic obstruction, which appears as a mosaic pattern within the left ventricular outflow tract. As you can see here, during systole, turbulent flow is clearly observed in the left ventricular outflow tract. Color Doppler is also useful for localizing the level of obstruction. Typically, this turbulence originates right at the site where the mitral leaflet approaches or contacts the septum during systole. Here is another example of a cat with SAM. As we can observe on B mode, when the mitral valve moves anteriorly during systole and narrows the LVOT, the characteristic mosaic turbulent flow pattern appears on color Doppler. Typically, this turbulence originates right at the site where the mitral leaflet approaches or contacts the septum during systole. When the dynamic LVOT obstruction is detected, we can further evaluate its severity by measuring the pressure gradient across the narrowed LV outflow tract using Doppler echocardiography. Using continuous wave Doppler, we can measure the maximal velocity of systolic flow across the narrowed LVOT, and the pressure gradient is automatically calculated. In general, when the pressure gradient exceeds 30 millimeters of mercury, it indicates the presence of obstruction. If the pressure gradient reaches or exceeds 50 millimeters of mercury, we consider it hemodynamically significant. As you see in this case, the velocity is approximately 3.15 meters per second, resulting in a pressure gradient of about 39.6 millimeters of mercury. In this particular case, with a gradient of about 40 millimeters of mercury, we would categorize this as dynamic obstruction, but not yet in the hemodynamically significant range. It's important to keep in mind that dynamic obstruction is highly influenced by loading conditions such as preload, afterload, and myocardial contractility. Finally, always remember that LVOT gradient is highly dynamic. A single measurement may not fully reflect the obstruction severity. That's why a comprehensive assessment combining B mode, Doppler, clinical signs, and serial monitoring is essential for optimal management. Now let's move on to another important consequence of SAM, mitral regurgitation. As the anterior mitral leaflet moves toward the septum during systole, not only does it obstruct the left ventricular outflow tract, but it also impairs proper coaptation of the mitral valve leaflets and results in mitral regurgitation. The severity of mitral regurgitation can contribute to both volume overload and progressive left atrial enlargement, which increases the risk of congestive heart failure and thromboembolism. So, when evaluating cats with HCM and SAM, it's very important to carefully assess not only the LVOT obstruction, but also the presence and severity of mitral regurgitation. Let's wrap up this lecture. 55 hypertrophy in cats can appear as concentric, asymmetric, or focal patterns. These patterns can lead to dynamic LVOT obstruction. We assess key features like SAM, septal bulging, and papillary muscle abnormalities using 2D, M mode, and Doppler to evaluate their hemodynamic effect. Thanks for watching Part 2. In the next lecture, Part 3, we'll focus on LA enlargement, thrombus formation, and CHF in advanced HCM. Don't forget to subscribe to Vet Image Lab for more practical and focused veterinary imaging education. See you in Part 3.